Good evening, everyone. It gives me great pleasure to invite you to our masterclass today. Before we dive into today's masterclass, let's have a small recap of the previous masterclasses. So, our first masterclass was on fertilization, which was conducted by Dr. Sujata, and we had Dr. Ratna ma'am with us for inaugurating the masterclass series. The next session was on implantation. We had Dr. Sandeep Karnakaran sir with us as a speaker and Dr. Swaminathan with us as the chairperson. Both the classes were a huge hit. Now, moving on to the third session today. For today's session, I'd like to invite the chairperson, Dr. Sasikala ma'am. Dr. Sasikala ma'am is a pioneer in the field of embryology and she's had many successes to her credit. And madam has done her MBBS and masters in clinical embryology from Nottingham University. And she's an M grade 4 American College of Embryology and trained in ART from US, UK, and Germany. She's worked in multiple countries and has over 32 years of clinical experience and 22 years in ART. The speaker for today is Dr. Rajvi Mehta, ma'am. Madam is a well-known personality in our field and she is the convener IFS SIG on holistic medicine and she's one of the first doctorates in human IVF in India from ICMR's NIRRH. She has over 3 decades in human IVF and she's a researcher, clinical embryologist and trainer. And she's the treasurer of ACE, SIG Holistic Medicine and IFS, an invited speaker to many conferences including IFFS and ESHRE, consultant Cooper Surgicals India, and she's the author Imagine If Westland Publishers India. It is an honor to have you with us here today, ma'am. So on this note, we'd also like to let you know that the next masterclass is on April 3rd. It is on the science and expertise behind IVF and ICSI by Dr. Gaurav Majumdar. Rajvi ma'am, I kindly request you to start your talk.
As I was just mentioning, it has quite a colorful journey. It starts pre-birth and it goes into a dormant state for a long period of time, as if in a state of hibernation. Then there is intense activity. Most of them just manage to die away. And then you have that which makes the crux of life. And in this next 1 hour, I'm trying to cover as much as possible of this journey of the oocyte. So we are talking about the first part, that is the state of the oocyte, how it is totally dependent on its neighboring cells, the neighboring fluids, the follicle, and the hormones. Then comes the state of oocyte maturation, where it is now ready to receive the sperm. And after it is ready to receive the sperm, and the timing and the matching of the timing between the oocyte and the sperm is so crucial that the phase of oocyte activation and finally fertilization takes place. Now, it is very important for all of us who are working in the field of IVF to understand the basics and biology. I always say ICSI, IVF, ART is not about just mixing the eggs and the sperm or injecting the sperm into the oocyte. You do not even need any qualification for that. You need extensive amount of skill, which can be acquired by anybody without any knowledge of biology. But it is so important that we understand what we are doing. We understand the basics of biology, the basics of cell behavior, and then we are in a phase as an embryologist to really understand what we are doing and why we are doing, what the importance of every phase of whatever we are doing. Now, the first thing is that when we are talking of oocyte maturation, how in vivo the oocyte, what is the time frame when the oocyte matures, what exactly happens, how do we mimic it during our ART journeys, how do you assess the oocyte? It is very easy. We can just superficially look at the oocyte. Okay, polar body is released. It is M2 oocyte. But really, how much do we assess? What information it communicates to us? What does it tell us? And then I'm going to talk about oocyte activation, which is happening naturally in vivo. And in cases where we need to artificially induce oocyte activation. And finally, in today's day and age, we cannot conclude any lecture on oocyte without talking of cryopreservation. I initially intended to even talk about using induced pluripotent stem cells to generate oocytes, but that would become too long a topic, too much of basics. So I thought I would restrict to something which can be covered because one need not bombard somebody with too much of information. So what is this journey of the oocyte? So let's put it, I'm going to start from very basic. So some of it me going down to medical school or for the basic biologists, maybe even going down to high school. But when we study at that phase, there's no perspective. It is just information. Now, when we work in the field, the basics make a lot more sense. Whether it is biochemistry, the cycles, which were just sort of memorized, now they make a lot of sense. So what really happens is in the in the fetal stage, the primordial germ cells just undergo several mitotic divisions. And after the mitotic divisions, you have plenty of oogonia. And these oogonium cells undergo further. One second, I'll just get my marker. Give me a moment. Oh, oops. Apologies. Sorry, I was just trying to. Yeah. So we have the oogonial cells, they undergo further mitotic division, and you have a primary oocytes. And these primary oocytes are in the primordial follicles here within the fetal ovary. And as you can see, it is surrounded by a lot of other cell types, and this is the
Slides are not visible, I think.
not visible. Okay. Are you there?
Yeah.
Full screen? No, it's not full screen. One minute. Okay. Yeah. So this is the primordial follicle in which the primary oocytes are present. And they remain in this state. They become the primordial, becomes the primary follicle. And the first difference is that the neighboring cells, which have a flattened appearance, go into having a cuboidal appearance. So it gives some resemblance of a follicle. And it is at this stage that it is remaining within the fetal ovary, which is what we would call a GV oocyte and an oocyte which has two sets of chromosomes, and it remains dormant till it gets post puberty, it starts getting exposed to the gonadotrophins. And once it gets exposed to the gonadotrophins, every month few follicles start growing. And in response to FSH acts on the neighboring granulosa cells. The granulosa cells, as you can see here, proliferate. And the oocyte has a distinct zona and the clear-cut germinal vesicle, which contains two sets of chromosomes. It is this becomes the follicle, and when the follicle enlarges, even then the oocyte is still sleeping. Why I'm putting this emphasis is that all this while the oocyte is dependent on the neighboring follicular cells, primarily the granulosa cells, which is supporting its existence because there is no activity happening within the oocyte. And as the follicle keeps growing, and as it keeps growing, the oocyte is still dormant. It is only about 37 hours with the LH surge, or what we do in vitro by giving a GnRH agonist or HCG, that the oocyte, which I would say, which has been gets uh, activated and starts the process of maturation, which would mean the completion of first meiotic division, so that diploid cells starts the first meiotic division, releases the first polar body, which is a simple cell division, but very little cytoplasm goes to the polar body. And that is the reason when we want to study the chromosomal status of the oocyte, one used to study the polar body. So here you have the secondary oocyte, what which is arrested again, and the is where we start getting activated ourselves, because this oocyte becomes very crucial for us in the field of IVF. Now, what triggers the resumption of meiosis? So the oocyte which has been arrested in the meiotic prophase, in response to the gonadotrophins, the follicle grows, the oocyte remains as it is, and when the FSH levels rise, the neighboring cells start producing estradiol, and it is in response to the estradiol peak that you see here that the pituitary gets the message of the LH surge. And it is in response to the LH surge and the peak of the LH surge which initiates oocyte maturation. And therefore, while we are considering the LH surge, because it is after 36 to 37 hours after the LH surge that the follicle ruptures, we are mainly concerned as the biologist because that is going to time the resumption of meiosis of the oocyte and the availability of a mature oocyte, M2 oocyte. So it is totally dependent on gonadotrophins. And subsequent to LH surge, of course, progesterone production starts and the endometrium starts building up for acceptance of pregnancy. So this LH surge becomes crucial for the oocyte because it is in response that meiosis resumes. So for decades together, the oocyte, which was just arrested in the meiotic prophase, resumes meiosis. Now, the completion of first meiotic division, I showed you in response to the LH surge. Now, this is the first is the germinal vesicle oocyte, which has two sets of chromosomes. And during the process after the LH surge, this germinal vesicle breaks down, so you do not see any nucleus. And finally, it undergoes division. The oocyte undergoes division, the first meiotic division, to release the polar body here. And this is what we call the M2 oocytes. In terms of all our work in ART, important that we get a mature oocyte. And especially when it comes to ICSI, we definitely need this oocyte because it is next to impossible to mature a GV oocyte in women. And even if we get an M1 oocyte, in most cases, yes, incubation for a period of time, we may get M2, but that's not the ideal way of functioning. And timing becomes extremely crucial because I've laid so much emphasis on the timing between LH surge and receiving the getting the M2 oocytes. Now, how did one come to this timing? How long does it take to mature? And I think one of the most classical studies that have happened were done by Professor Edwards. And his early work was primarily related to in vitro maturation of oocytes. And the story goes that gonadotrophins had just come in and they were using gonadotrophins in mice and they found that immature mice, when given gonadotrophins, would mature. So they thought that while donor insemination programs were on, they thought that if you could mature oocytes also, then you could time insemination with the maturation of the oocyte. The problem they faced was that whenever they gave gonadotrophins to mature mice, everything went haywire. So it was not as nice as making an immature mice giving gonadotrophins, but it was quite a disaster when mature uh, the mice were injected, and same thing happened in women. And that is the reason they attempted in vitro maturation. So it's very interesting to see that before IVF, in vitro maturation was started. And they got GV oocytes, and they would find that by incubation, these oocytes did not mature. And Edward had developed Pincus, the famous person who developed the OC pill, and did the preliminary work on in vitro fertilization, that oocyte maturation takes 18 hours. So they waited and waited. Then they added hormones to the culture medium. They did co-culture. They used feeder cells, hoping that this oocyte would mature. And they did HCG. And 18 hours later, also the oocytes remain as it is. So I can imagine how difficult these experiments is because if somebody has told you that they would mature in 18 hours, you would extend the time by half an hour, maybe at a time. And to even go to 25 hours, I don't know how many oocytes would have been wasted. And finally, after 25 hours, and this is Bob Edwards' words, he says, joy abound with nuclear fading. So the moment he saw the germinal vesicle fading, there was a tremendous joy to say, okay, something is moving. Because at that point of time, when you have a GV oocyte, we are not even sure whether it's alive. Of course, it's not degenerating, but is it living? So it was quite a mess because one wouldn't know what's happening. And imagine once the GV faded, and then another 12 hours later, the first polar body was released, and we got a metaphase 2 oocytes. And in my mind, this is one of the most classical series of experiments because if we note the timing from acquiring a GV oocyte to getting an M2 oocyte, it is 25 hours for the GV to break down and another 12 hours for the metaphase 2 oocyte. So it takes 37 hours for a GV oocyte to mature. And it is based on these preliminary experiments that we schedule all the infertility work around 36 hours. Of course, we don't do it around 37 hours because you don't want to take a risk that you go for a pickup and the follicles are ruptured. Also, you have multiple follicles, you're in a surgical procedure, however minor. So we keep the pickup timing around 36 hours. The question remains that once the antagonist protocol started coming in the early days and the timing was not right, people went in for early pickup. However, we need to remember that if oocyte maturation, this biological phenomena, which takes 37 hours, cannot be shortened by any way, it takes that long. So I'm in a very strong opinion that even if we have picked up aspirated the follicles early, they should be left with the cumulus cells for a period of time for completing oocyte maturation. So when we have a cohort of follicles, it's not that all of them would have mature oocytes. There may be some which may be in the intermediary phase, and we should keep it in the similar environment as close as possible to that in vivo. So if we summarize this process of maturation, the oocyte remains arrested at the diplotin phase of the meiotic prophase for decades together, and it's only after the LH surge or HCG or trigger or an agonist trigger, it starts resumption of meiosis and completes its first meiotic division 37 hours later. So we should not forget timing and the importance of timing in oocyte maturation in vitro. Now, how do you assess the maturational status of the oocyte? Now, one is, you show these nice pictures of a polar body, but when you aspirate the oocyte from the follicle, you cannot see it. And supposing you have denuded it and you get a GV oocyte, you can't do anything about it. So it is as good as wasted. So I feel that if you're stimulating a patient and then you land up with a lot of GV oocytes, in most cases, if it is something to do with the timing, then the patient, because if you are getting so many GV oocytes, it could be some various factors. It could be the hormones, it could be the timing that the trigger has been taken. And so we need to keep it. And here I would draw your attention in the very early days of IVF, people didn't know when to inseminate. So the idea was you got the oocytes, maybe 36 hours, and you added the sperms. The fertilization rates were very low. And it was only after 4 years, after the first baby was born, that Alan Townsend did a series of simple experiments, incubating the oocytes for 2 hours, 4 hours, 6 hours post pickup, and then finding what the fertilization rates were. And he easily found out that incubation needed 4 to 6 hours before you add the sperms. And this was a very important finding because possibly when you have a cohort of oocytes from a different follicles, they may be, it's not that all of them mature exactly at the same time. And possibly you're giving time for the oocytes to complete the first meiotic division, and that is the incubation time. So, which also possibly reflects when we are doing now denuding and doing ICSI. So, how do we realize whether the oocytes are mature or not? And in that case, the first thing is you look at the oocyte coronacumulus complex because LH or the HCG not only triggers oocyte maturation, it starts acting on the cumulus cells surrounding the oocytes and the granulosa cells, which start converting from estradiol to progesterone producing cells, and the cumulus cell starts loosening up. So if you see a tight cumulus like this, very sticky and a very distinct form, rest assured, the oocytes from these cumulus cells or within these cumulus cells are going to be germinal vesicle. Leave them alone. Keep them incubated for a longer period of time before you denude them for ICSI. And even if you're planning to do a conventional IVF, keep them for much more than 4 hours, even 18 to 24 hours till the cumulus expands. Now, classically, we don't get such tightly packed cumulus. Sometimes maybe from very small follicles, but otherwise you get a good, well-expanded cumulus. But we all know those are working in the field that you cannot really see, you can never see a polar body within this cumulus cells, especially even under any microscope. But if you see expanded, the probability of getting a mature oocyte or an M2 oocyte, an oocyte with the first polar body released, is extremely high. So this is when you see an expanded. And for a safe side, you incubate them for 3 to 4 hours. So your probability of getting an M2 oocyte. Because the fact is, most of all our patients spend nearly ₹1,00,000 just for stimulation. And if we get immature oocytes, it's a waste. So what is the point in stimulating? Because we are not going to get the oocytes for injection. And some cases, if they're hypermature, sometimes where you have, they have luteinized follicles, or you have, the high levels of LH already in the follicle before the LH surge. In that case, you may get very dark, compacted, which is very different from the atretic oocytes. And the prognosis of this is not good. So oocytes which have been exposed to levels of progesterone prior to the elite surge, then we may get this kind of complexes. So now I just mentioned the timing is very crucial, and you have aspirated the oocyte. At that point, in the last few hours of oocyte maturation, the whatever is there in circulation would have entered into the follicle. So maybe the last 2 3 hours, the oocyte is not as dependent to the follicular fluid and the follicular environment, but it is surely dependent on the cumulus cells. And in the GV oocyte, you'll find the cumulus cells tightly. So the follicle is expanding. It's reached nearly the stage before the elite surge and the pre-ovulatory follicle, where the GV oocyte is going to become M1 and M2. Here you find that the cumulus cells are closely exhibiting, and I've purposely shown this picture of a cross section of an oocyte coronacumulus complex. And what you can see here that in most cases, the cumulus cells actually have projections which go into the oocyte. And as the oocyte matures, these projections start breaking up. So you can clearly see in various locations that the projections have come off, but some are still there. That means, because like we said, the oocyte is dormant right through its early life, and it still needs to survive, and that nutrients are provided by the cumulus cells. So if we prematurely denude them, then the oocyte is not in the capacity or capability to get matured. And therefore, we do not succeed as much with in vitro maturation unless you have spatial conditions and very specialized media. So I say that especially after the elite surge, it's just the question of time. Leave them alone with the cumulus cells, and that a series of experiments, right from the experiment I talked about, Alan Townsend incubating the oocytes for 4 hours before adding sperms for conventional IVF, or the percentage of GV oocytes versus M2 oocytes with the duration of timing from elite surge or from the trigger, because elite surge we don't know, but from the trigger to pick up. So denudation when? At least 2 hours of incubation post pickup. And I say pickup time is something which can be variable. We do say pickup at 36 hours, but it could be plus minus, but we should time it from the time of the trigger. So that is because maturation depends on the trigger, not on the pickup. So it is better to time it 38 to 39 hours post HCG or the trigger. So we are going to get the good amount of mature oocytes. We do not want to increase the time, because then again, you don't want hypermature oocytes. So this would be the denudation time. There is no need. These problems do occur when one has cluttered or clustered many cases together. So if you are going to do 10 pickups at a time, obviously the first one, you may do a denudation. Somewhere in between, the denudation times will not be maintained, or they may be shortened, or they may be too prolonged. So one has to time in such a way that we do maintain this time frame from trigger to denudation. And then we go ahead assessing the nucleus. So we have assessed the coronacumulus complex for IVF, or even to decide on denudation. But most often we do it on objectively based on timing. And then you get an oocyte. After denudation, clear germinal vesicle, we know it's immature, incubated. You have the M1 oocyte where the germinal vesicle is broken down, and M2 oocyte. And this we are all very clear because we have to do an M2 oocyte injection. We cannot inject into an M1 oocyte which has diploid 2 sets of chromosomes. We can never even dream of it unless you have permission of the patient, where these kind of oocytes have not fertilized and you're using it for practice. But otherwise, procedures can only be done to M2 oocytes. Now, we do see certain abnormalities in oocyte, and I'm only referring to the nuclear abnormalities. Rare cases, we generally don't see a lot of nuclear abnormalities in oocytes. Rare cases where there are two germinal vesicles, or there's no polar body, or so here we are only looking at the presence of M2. However, remember that this oocyte is going to sustain the embryo till day 2 or day 3 post fertilization. And it is not just the nuclear maturity. It is not that the chromosomes from the oocytes and the chromosomes from the sperm are important. This oocyte should facilitate fertilization, syngamy, and provide all the internal cellular organelles for the blastomeres that are going to form. And therefore, cytoplasmic maturity in that 37 hours post HCG There is an increase in the volume of the oocyte. There is a lot of replication and redistribution of cytoplasmic organelles, which would include the mitochondria, the endoplasmic reticulum, RNA synthesis. Remember, there'll be a lot more protein synthesis that would be required to take place for the oocyte to for the fertilization and the first few cell divisions. The zona becomes thickened and the gap junctions disrupt. That is the connection that we are having between the oocyte and the cumulus cells will need to disrupt. So you see that so many activities, unfortunately, all these are very internal, and with the current uh, techniques that we have, the means that we have, we cannot see all this with the current microscopic setups we have. So we need to assess the oocyte on some kind of abnormalities or assessments. So what are the assessments we do? We look at the thickness of the zona. We look at the space between the perivitelline space between the ooplasm, cytoplasm, and the zona. We look at the presence of vacuoles or refractile bodies or granularity. Now, the first thing is that if there is a increased perivitelline space, the space between the ooplasm and the zona, it is not a healthy indication, because if some of you have had oocytes which haven't fertilized and you leave it in the incubator, after a few days you'll find them shrinking and becoming a very tight ball. The zona remains as it is. The first indications of degeneration would be when there's increased space between the zona and the ooplasm. So you can see here, as the space increases, the these quality of the oocytes is compromised and we do not have a good prognosis with them. Then there are certain cases where you see vacuoles, and again these just are empty spaces which are filled with fluid. Now, a couple of small vacuoles may not really make a big difference, but a large vacuole will make a big difference, or multiple small vacuoles. And again, it's a oocyte is one cell, and if there are so many vacuoles and fluid-filled spaces, it's just common sense that it is taking over what should have been occupied by cellular organelles, and this would have affect the further development of the oocyte post-fertilization or even for fertilization. Again, it's not very common to see a lot of vacuoles. There would be cases and there would be certain indications where it happens. Then you see what is called as the aggregation of the smooth endoplasmic reticulum. And the reason for this is unclear, but it has been shown that in most cases, if you inject such oocytes, there would be fertilization would be normal, but these would not lead to a clinical pregnancy. And there are a few reports where a clinical pregnancy did occur after injection into an oocyte with an aggregation of the smooth endoplasmic reticulum. There were obstetric complications, and the baby also had a lot of complications. So the question is, if you get such oocytes, it is best to avoid injecting them. If you have it and cohort is like that, then one should avoid going through the smooth endoplasmic reticulum. But this is something which one is cautious. But fortunately, we don't see it so frequently. So maybe it is a kind of an inherent problem, which is the cause of infertility. However, something that we see very quite frequently is the clustering of organelles, or because we don't know what organelles are, that is not visible with the current inverted microscope, but there is a kind of appearance of granularity of the granularity in the cytoplasm. And again, you can see it better with phase optics, but it has been found that clustering, there are some reports which show that clustering, too much of clustering, has lower implantation potential. So the clustering can be centralized right in the center of the oocyte. It can be peripheral. It can be dispersed all over the oocyte. So clustering may vary. Also, whether this is a natural phenomena or a result of extensive stimulation, one doesn't know, because there will be very, very few reports or people who have experience looking at oocytes from non-stimulated cycles. But there have been studies which have looked at the presence of cytoplasmic granulation and the absence of cytoplasmic granulation. And as you can see, there's not much difference in the fertilization rate, whether there is slight or severe granulation, and the number of embryos transferred also was not very different. But there are some other studies which have looked at granulation pattern. Means what they're trying to look at is whether these granules, what is the type of granules first they look at it. And what they find is that if there is fine granulation all over, or is it centralized, or is it uneven, or it is just dispersed or peripheral. And they find that the fertilization rate is variable with response to the kind of granulation. And most of the time, one does see kind of fine granulations or centralized granulation, and it doesn't seem to impact the fertilization rate. However, if you see a dispersed granulation pattern, as has been shown in the last histogram bar or the group, you can see when there's dispersed granulation pattern, there is a high number of cases where your fertilization rate is much lower. So it does shows that dispersed granulation is associated with lower fertilization rate, and these were donor oocytes. So we are not talking of cases where there is PCO or endometriosis or other issues which are existing in the reproductive system or hormonal abnormalities. You are looking at healthy women who are part of a donor program. But in these cases, if there is dispersed granulation, it is associated with compromised fertilization rate as compared with the other granulation. A fine granulation actually gives better fertilization rate, but that between centralized is not too different, and central granulation pattern is relatively more common. Now, how do we use this kind of information? And it's a couple of years, a Chinese group who has looked at hundreds and thousands of oocytes and studied the granulation pattern has actually given some kind of predictive value. Now, the fact remains that when we see the oocytes, once the nuclear maturity is there, we just decide, inject, and go ahead with it. And then we grade the embryos. But history always helps, because I'm sure anybody in the medical profession, the most important part would be history, because it gives you an indication of the background and how things may progress. So what they have done is they have evaluated fertilization, M2 oocytes. They've studied the granulation pattern, whether it's fine or it's dispersed or is uniform or centralized. UG is uniform and centralized is because obviously they're not going to go further, or we are not going to look at them further. Then, if you have the embryo grade, so embryo grade is excellent because we judge the cleavage stage embryos good, and then you have fine, fair, poor, so it's not the best. And then you go into the priority. So even when you have excellent embryos, is the information of the granularity pattern helping? So they give the first priority when it is fine granulation, and last priority when it's dispersed granulation. And this is the same if you have good embryos. So if you have excellent grade embryos, in that those with fine granulations would be having the highest priority. And obviously the second stage good would be there. And if you're having overall granulation, good embryos, excellent embryos with granulation, the first goes to the embryos which are coming from excellent looking embryos with fine granulation pattern. And this is how they have graded. So even if the embryo is good, but if they have fine, it's not excellent. So you have an excellent embryo, but the granulation pattern was centralized, and a good embryo, grade 2 maybe, or I would say, you would still go for one with the fine granulation pattern. So it's a very interesting study. Whether one can directly utilize it, I don't think so. But it is something which will get us to look at our own data, study our own patterns. And these kind of studies guide us to looking at our own information, what we can gather, and then create our own algorithms for selection of transfer. So while on one hand, you have all the AI models coming in, but by the time they get into clinical practice, by the time we are able to spend the time and I would say money on it, at least we can look at our own data to guide us how we can improve the probability of pregnancy in our patients. Now, while we are looking at the cytoplasmic granularities, to summarize, uh, as of now, except for these few studies on granularity, SER is directly associated with abnormal outcomes. So other assessments are still very, very subjective. So I would not say that you discard embryos or not inject oocytes unless there are TESA sperms. You don't want to inject the free sperms you have. But otherwise, do go ahead with ICSI, but keep them at the lowest priority. So except for SER embryos, or embryos generated from SER oocytes, go ahead, but give it the least priority and maybe do your own data, and maybe we can have data from our own country to see whether there is any sense to the granularity pattern study that is reported. Now we go to the next part about fertilization and the completion of meiosis and oocyte activation. So now the oocyte is
Ma'am,
mature.
can I
Yeah,
interrupt you here, ma'am?
sure. Go ahead.
So it was so much of information, ma'am. So I think compared to this, the questions I'm going to ask is very, very basic. So let's just have a small 2-minute break and we'll have a small quiz. I'm just going to launch it. Please let me know if you can see it. Are you able to see the questions?
Yes, it's visible.
I encourage all of you to answer.
We are not allowed, right?
Ma'am, you can, ma'am, absolutely. Anybody can.
Request all the delegates to answer.
Anybody, ma'am, all of you.
This is not a competition or anything. It is just to brush our knowledge. I think Rajvi ma'am is such a teacher and we are honored to have her here. She's been talking like, continuously 40 minutes, brushing the
Maybe
basics.
for a break for ma'am.
Yes, definitely.
I didn't realize 40 minutes.
Yeah,
I may
yeah.
overshoot.
That is the passion as a teacher you have, ma'am.
True.
I can see only 8% of the delegates are participating. I encourage all of you to participate. This is just, there's no right, wrong, or anything like that. Just to clarify whatever small doubts we have.
All your answers will be totally anonymous. We are just going to discuss the answers. That's all. See, the idea is to just answer. Yeah. So it is just a self improvement. That's it.
So almost 50% have participated.
Nice. You have another quiz at the end of the talk?
Yes, ma'am.
Oh.
Sindhu.
Yes, ma'am. Ma'am, good
It's
evening, ma'am.
over. Was this over or
No, ma'am, it's happening, ma'am. You can answer, ma'am.
the 5 questions I answered next?
That's all, ma'am. 5 only, ma'am. Remaining 5 at the end of the session, ma'am.
Okay, I don't know whether I thought I finished my answering.
Too easy for you, ma'am.
No.
Rajvi ma'am's presentation, every slide I felt like I can ask question on this, but then I think everyone will run away.
I may be wrong also. I don't know.
Somebody is saying can't see questions, Sindhu, in the chat.
Okay.
Can you just
check
check again? Anupama Patil. Can you just check whether...
Vasu, can I ask question to Dr. Rajvi?
Definitely at the end of the session, ma'am. Lots of
Okay.
questions, provided ma'am is not exhausted.
No, in between now everybody's answering, can I ask her a few?
Sure.
No, I just wanted to know, like you said, 38 to 39 hours after the HCG you pick up. Won't it rupture?
No, I didn't say pick up. I said
maturity.
36 hours there's a pickup and you get an M2 oocyte around 38 to 39 hours. So that's why you incubate it post pickup.
Okay, even for ICSI, you even if for ICSI, you say you want that 2 hours. Okay.
Yes. So I'm saying 2 hours. But because, it's better to time it with the time of the trigger.
Okay. Oh, to time of the trigger.
Yeah. If you go for 38, 39 hours, you've lost everything. All the
Okay.
follicles would have. You're right.
Yeah. That is why I was wondering. Maybe I didn't see.
No.
Okay.
I'm talking of maturation.
Maturation. Okay.
Yes.
Thank you. I'm Dr. Vijay Ganesh.
Hello.
Hello.
We'll close the quiz in 30 seconds, ma'am. It's almost 5 minutes.
Yeah.
Almost 80% have participated. So okay, I'm closing the quiz now. Let me just share the results. Are you able to see? 1 second. I'll show correct. Are you able to see?
Yes.
Okay, so the first question is, which of the following is true about the number of primary oocytes in a female? So the right answer, as answered by most, 77%, is the number decreases from birth to menopause. So in which stage of meiosis is the oocyte arrested before ovulation? So it is, I've asked before ovulation. So that is prophase of meiosis 1. So if it is after ovulation, it is arrested at metaphase 2. So and after ICSI, it completes the meiosis 2. So it's a trick question. So 50% have said prophase 1 and 44 have said metaphase 2. And how does the oocyte communicate with the surrounding granulosa cells during its development? So majority have answered correctly. It's through the gap junctions and paracrine signals. And which of the following is true about the lifespan of a human oocyte after ovulation? 89, almost 90% have answered correctly. It can survive for up to 24 to 48 hours. And ma'am had shown a beautiful picture. So that's why I wanted to ask the question. Tight cumulus is associated with which kind of oocyte? So 80% have answered that it's GB oocyte. And that's correct. So I'll stop sharing the results now. Ma'am, please continue with your presentation.
Okay.
All of us are good students, ma'am, I think.
Yes, ma'am. Everyone's paying attention.
Too simple.
No, you're making it simple.
Actually, a
Okay.
whole lot of physiology is so complex. If a teacher like you teaches, I think we will not read books.
Yeah.
Okay, nice to hear that. So now we come to the second phase of oocyte activation. So one, you have the M2 oocyte. Again, it sits quietly before it completes its meiotic division. So now what exactly is oocyte activation? Now we have said that it has completed the first meiotic division, that is the release of the first polar body. And then for it to get fertilized and for it to accept the sperm and get fertilized, the timing is crucial. So if the oocyte is just waiting there and the sperm comes in, there is always going to be a mismatch. So the period of oocyte activation is when the injection of the sperm into the oocyte triggers oocyte activation. And this is what we are going to look at. Now, what exactly happens in oocyte activation? Now, the sperm binds to the oocyte, acrosome reaction takes place, the sperm enters into the plasm, and the sperm brings with it what is called as phospholipase C zeta, which is an oocyte activation factor. So that's a signal for the oocyte to start preparing for fertilization. Because if it gets activated early, there is going to be a problem. So what does it happen? It triggers oocyte activation. Now, what does it mean? When it says triggers oocyte activation, the first thing, the sperm has to send a message very quickly that once sperm has penetrated, there has to be change in the zona so that the second sperm does not penetrate. And there is an exocytosis of the cortical granules to prevent the second sperm or more sperms to coming in. So sperm enters, releases phospholipase C zeta, and there's a rush of the cortical granules to the periphery of the oocyte. Then the meiosis gets completed so that the second polar body is released. So you see the release of the second polar body much earlier than the seeing of the two pronuclei. Then comes the pronuclear formation, and then, of course, the zygote formation. So when an oocyte does not fertilize, the problem could be the sperm. That is, the sperm does not have enough of phospholipase C zeta, or it is not active enough to activate the oocyte, or there is a problem in the oocyte which does not respond to the phospholipase C zeta. So failure of fertilization could be either. Now, what exactly happens when I say? So we said, what is the result? Once phospholipase C zeta is released. Now, in the case of sperm, the acrosome reaction, the entry of the sperm does it. But in ICSI, we inject the needle. So when earlier ICSIs were done and the needle was just injected and the sperm release, fertilization rates were very poor. So now what do we do in ICSI? We go into the oocyte, we go into the ooplasm, aspirate some of the ooplasm, which triggers the oocyte, which is a signal that the sperm has come in. So when the sperm or the needle enters the oocyte, within 10 to 15 seconds, there is, because remember, this process has to be very quick in nature, especially when there can be a risk of multiple sperms entering into the oocyte. So within 10 to 15 seconds, until about 4 to 12 hours, there is a spike of intracellular calcium. It's all about a play of intracellular calcium oscillation. So these spikes, after every 1 to 5 minutes, there will be a 10 to 15-second spike. Again, every few minutes, there's a spike. And this remains for 30 minutes to 1 hour, where between 1 to 5 minutes, there is a spike of calcium ions. So as if there is a release of calcium ions. And afterwards, the amplitude gets shorter and shorter and shorter, and it stops. So this is what triggers the whole transformation of what was oocyte activation, movement of the cortical granules, triggering completion of meiosis. Now, what does this calcium ions do? So the first thing is there is a spike, and because of the spike, the cortical granules, what do these granules contain? They contain proteases, they contain glycosaminoglycans, peroxidases, which will go to the plasma membrane, modify it, modify the zona to block polyspermy, because that's the first thing that needs to be done, because there is no way you can have 3 sets of chromosome within the oocyte. Then it activates the oocyte for the segregation of the sister chromatids, which was partially done with the first meiotic division and complete meiosis. So this is the role of calcium oscillation. Now, just a migration of cortical granules. So you can see the cortical granules here, which are now started moving towards the periphery and starts going into the perivitelline space. So some of these ultrastructural studies actually give us much more information. So here you can see it's all visually summarized, where you see the sperm binding, you have the PLC zeta release. This causes the endoplasmic reticulums to start releasing the calcium ions. Calcium spike releases to the cortical granular movement and completion of meiosis. So now what happens when there is total fertilization failure? And I think this is every embryologist fear. Come next day and see no fertilization. And that's one of the reasons everybody wants to do ICSI and make sure that fertilization occurs. But remember, total fertilization failure is not always because of the sperm. It can be because of the oocyte. So even after IVF, one expects about 3 to 5% fertilization failure, total fertilization failure. We are talking when none of the eggs fertilized. Of course, there will be incidents where you will never have 100% fertilization. You will have about 60-70%, which will be depending on various causes, right from age and stimulation protocols. But even after ICSI, one can have 2 to 4% fertilization failure. And this is, like I said, not just because of IVF, it can happen because of failed oocyte activation. And as I said earlier, it could be insufficient phospholipase C zeta, or it could be the oocyte factors. So now, if after ICSI also there's failed fertilization, then one has to artificially or extrinsically activate the oocyte because the internal mechanisms have not functioned. And what one wants to do, one wants to give a spike of calcium and lead that so that the entire internal mechanism goes up, is initiated. And one is trying to mimic calcium oscillations. But unfortunately, we cannot really mimic oscillations. We can cause an influx of calcium, and it can be done in various ways, electrical, chemical, mechanical. But what is generally being used is the use of the chemical method of using calcium ionophore. And this calcium ionophore basically is bound to an ionophore, which brings about calcium entry into the oocyte, because this ionophore makes it permeable to go through the lipid membrane and causes an influx of calcium from the culture medium, which causes an intracellular rise of calcium. But in artificial oocyte activation, we cannot really create oscillations. There will be entry into the oocytes. And therefore, in cases of total fertilization failure, one uses calcium ionophore. So post-ICSI, the oocytes are incubated in this calcium ionophore solution for a period of time, after which is triggering the oocyte activation externally. Now, anything, in IVF, we may try to compare whether it works. Remember, we have to identify patients or groups where you need an additional intervention. Everything cannot be for all. This is one of the studies where they did one to nearly 1200 plus ICSI cycles versus where ICSI failed. And they went in ICSI cycles and ICSI plus oocyte activation, artificial oocyte, in the same group of patients, and naturally higher pregnancy rate because ICSI has failed that they have gone for artificial oocyte activation in a subsequent cycle. And they found better blastocysts, lower miscarriage rate, but it did not help a group of patients which had primary ovarian insufficiency. Now, the data in literature is always conflicting, and it takes time to really understand because it's not that the studies are different, the patient population is different. There may be minor variations in which manner they have subjected these oocytes. So when they had a meta-analysis of nine articles, they didn't find great evidence of the use of artificial oocyte activation. But when the number of articles increased over a period of time, they did find that after ICSI results, there was an improvement in the ICSI results with fertilization, cleavage, blastulation, and implantation rates. And it is understandable because the first block in these patients is because of failure of fertilization. So if that block is overcome with artificial oocyte activation and you have fertilization, then naturally the subsequent timelines are going to work because the blockage in terms of failed fertilization has been overcome. But again, we have to be cautious when you are intubating in such agents, whether this preliminary calcium influx could have long-term consequences. There is a group which actually tried rescue site activation, means that they come on next day and they find that fertilization has failed. And then they give us they subject these oocyte to the calcium ionophore, and they find that in some cases, of course, it's not found to be very successful because the oocyte has matured significantly. Because by the time you look 16 hours later, it has become much older. But in some cases, when they did that rescue oocyte activation, if the polar body has been released in a very short period of time, in less than 2 hours, post this artificial oocyte activation, they find that there are better qualities and they do get embryos in this case. And also when the embryos don't arrest, also the timing is much shorter. So and this is really understandable that in these patients, if artificial oocyte activation would have been done at the start, they would have benefited. But again, we need to identify if there is a way and mean to identify which patient population will benefit from this, because it will not be rational to subject all the oocytes to calcium ionophore. So maybe if appearance or if there are certain indications, and I don't see any much work going on in this field, but that would be a good clue because that will leave behind the fear of total failed fertilization, help us to move more towards IVF, at least in non-male factor cases, and where we have a natural selection of the sperm rather than we trying our selection. Because I do believe that even the best embryologists in the world are not as good as the Zona. So we need to give it that time. So now we come to the third phase of oocyte cryopreservation. And it's something which we need to talk about in this day and age because the number of cycles of oocyte cryopreservation worldwide are increasing. And more so, most of these cases are now for uh, what would call a social egg freezing. There are a number of terminologies. Now, first of all, if we need to understand that when we're going for the cryopreservation of gametes, semen cryopreservation happened nearly 75 years ago. But the first report of oocyte cryopreservation happened in 1805, and it was only about 10 to 12 years back, about 12 years back, it was still considered experimental. And the fundamental reason is that when we talk of semen or sperm cryopreservation, first we are working with a large number of cells. So even if you lose few, 50% survival, you're still better off. The other major reason is that sperms have very little cytoplasm or literally no cytoplasm. And the major cell injury happens because of uh, crystallization, ice formation, and crystallization, which damage the cellular organism. So here you have an oocyte, the largest cell in the body, full of cytoplasm, and naturally the damage rates are very high. And that's the reason you had a wide discrepancy between the Y factor and the X factor in a way where the survival of oocytes, the preservation of oocytes was much, much more difficult than that of sperms. Now, why was oocyte cryopreservation? Was there not a need? I think so. There was a need, but it was not as much as sperms because it was technically more challenging. And I would say more for social reasons. One didn't think about it. The major problem was the difficulties with oocyte cryopreservation. They did not survive cryopreservation. And what kind of service can you offer when you're not sure that you're giving oocytes, they're preserving oocytes, and they come back after some time, whether it is because of fertility preservation or social reasons, and they are no longer surviving. So I think the game changer in oocyte cryopreservation came with vitrification. And just a word that, when we say something freezes, it means when you say water freezes, it gets converted to ice. And ice is a very bad word for cryopreservation because if ice forms, ice crystals can destroy anything. So if ice, too much of ice crystals, and ice crystals are not going to be having a specific shape and size. It can be in any size, any shape, can be sharp and damage the organelles. So vitrification is a state where you are bypassing the solid phase to go to a glass-like state. You're bypassing freezing to go to a glass-like state. And it's a phenomena where there is no ice and no damage. So technically, when we say oocyte freezing, technically, I mean, if you're talking to a cryobiologist, they will say you cannot have freezing. Because if you say freezing, it is not vitrification. But well, we are more into the colloquial talking to the patients, and we say, yeah, and this was the biggest game changer. And there are various protocols, and I'm not going to go to the protocols, but one thing I would advise anybody who's doing oocyte vitrification is please follow the protocol to the T, especially when it comes to the volume of medium. Remember, we use a higher concentration of cryoprotectants with vitrification, but even high is just 10% is the cryoprotectant. Rest is your buffer or culture medium. And that is made of water. And if you use lower volumes of culture media than that, what is advised, you will have osmotic changes. So you may vitrify well, but the osmotic changes, which would be there because it's open, it's not under oil, they can lead to osmotic damage to the gametes, to the oocyte especially. So be very careful about the volumes. And the fundamental principle of vitrification is it goes into the equation. There is an exchange of the cryoprotectant with the cytoplasmic fluid or the ooplasm, and then you have the expansion. So equilibration medium, wait as long as there is re-expansion. And once it goes to the vitrification medium, the timing is very crucial. You do not want to put it more than 1 minute till it goes into liquid nitrogen. So volume is crucial for the first two phases, and especially the timing is crucial for vitrification. Equilibration, if it is again, you can give it a few more minutes if required. And of course, the quality of oocyte. If the quality of the oocyte is compromised, vitrification can maintain it. It cannot improve it. Timing, pipetting, temperature, osmolality, all these are crucial like for any culture medium. Let's not think that it's a vitrification medium, equilibration medium, dilution medium, washing medium. They all contain a large amount of water which is susceptible to osmotic changes. And of course, use a volume and the warming as much as I would say more than warming protocols are more important. Now there is attempt to shift towards ultra rapid vitrification, ultra rapid warming, one stage. Results are looking interesting, but time will tell. I'm sure all embryologists very happy because if the time taken to warm can be reduced to just 2 minutes, I think it would save a lot of time. Now, needs cryopreservation? Yes, cancer therapy, most cases, fertility preservation. And more of the cases now are delaying pregnancy, what we call as stimulation. Now, cancer therapy, first and foremost, a lot of these female cancers are of the reproductive cancers. So we cannot provide the normal stimulation. We cannot delay the treatment of for the cancer. So this is easier said than done, like it's for the male. So it requires specialized stimulation protocols. Again, we need to be very careful about the stimulation so that it doesn't aggravate the cancer. So this is a totally different situation, and that's not my I qualify stimulation protocols for cancer patients. There are non-medical reasons, and there may be very whatever reasons. It's a personal reason. But now that the women have become educated in terms of reproductive aging, they do know that as they go older, the quality of the eggs will be compromised, and they're not yet ready to have a child. They want to see cryo preserve, which is a good thing. Now, what really happens? There are various, you call it social egg freezing, elective egg donation. A nice acronym is age banking, anticipated gamma caution. Sounds very interesting and very cryptic. But all in all, it's basically for social, personal reasons, no medical indication. Now, one thing we realize is when you're doing an ovarian stimulation for oocyte banking, or you call it first, we in these cases, we know that we don't know how these women are going to respond. When it comes to an infertile patient for coming in for OM pickup, you have a lot of data on that individual who has undergone several treatment cycles, maybe for IUI, maybe ovarian response. We don't have much information. Now, the question is, how many stimulations should be done? Should we get maximum number of oocytes from one stimulation? The question is, if something goes wrong with that cohort, all the oocytes would be compromised. Like, for example, I said elevated progesterone. Or should we go for multiple stimulation cycles? What should be the optimal number of oocytes? And we really don't know much about the quality of oocytes in this case. Should we go for quality versus quantity? In this case, definitely we need quantity. I mean, what it is, and all that depends on the age of the patient. So this is something which is a little tricky because there have been cases who have come for oocyte banking, and they come up and their first stimulation about 6 to 8 follicles only. Now, would she go for a second stimulation? So these are questions because one is never too sure of the response. Now, timing of denudation, remember in this case, we cannot prolong the denudation too much. But if we a lot about the immature oocytes, but here we have to keep into the timing because post-warming, we will need to give time to these oocytes to re-expand before we do inject them. So we need to maybe shorten the timing of the denudation to max 37 to 38 hours because we have to give in time that once we warm these oocytes prior to ICSI, they will need another 2 hours or 2 to 3 hours of incubation. What exactly happens with these vitrified oocytes? Well, there's not much difference in protein profiling, appears safe. And people have done studies of fresh versus vitrified. And you can see the fertilization rate is not significantly different. Fresh versus vitrified. If you look at the cleavage stage, it is not very different. Number of good quality embryos, vitrified give not a significant, but not a significant no, they did give a lower amount of good quality embryos on day 3 compared to 67% in fresh cycles. Vitrified gave about 46%, and that tells us that we may not essentially get a good number, so we need to have a sufficient number of oocytes. Another question that really comes in is that when these people come in, what age they come in at? Because very often people become alert about their aging only after the age of 36, 37, where already there is a compromise that is settled. So that makes a difference. Also, the level of awareness that is there in the patients, because many of them just think that they're going for oocyte vitrification. It's like a bank. We are going to store our valuable oocytes in a bank, and when we want them, we'll get them back. But they need to take into consideration that it is not essential that they get them in the same stage. Now, considering oocyte cryopreservation versus age, and you can see that, it would be understandable if less than 30 years, outcomes are very nice, but 30 to 34, it's acceptable, but more than 35, as would be anticipated, the outcomes do get compromised. And that is the reason if one wants to cryopreserve, there has to be a kind of awareness. But then, as people working in this field, there's not much you can do. If a person comes at that age, you still have to do it. So, but maybe this would be more of education overall to guide them to it. Now, quality of oocyte, and this is sibling oocyte study, which is interesting. And they find that, when you're looking at the quality of oocytes in the fresh oocyte versus vitrified warm oocytes, the day 3 quality of embryos, you can see the range that is there. Whilst in vitrified oocytes, the percentage of the good quality embryos is much lower. So it does show that maybe there is some compromise happening. Whilst when you look at the live birth rate, the numbers are very, very small, 4 out of 41. But it did not seem to be much compromise when it comes to the vitrified. But here we must remember, when you're talking of fresh oocytes, you are actually talking, in these kind of sibling oocyte studies. So overall, it does appear that we are fairly okay when it comes to vitrification with oocytes, and that is the reason the experimental tag was finally removed. But remember, it all depends on the hands of the people who are doing it, because the technique is standard, but the skills are variable and it is highly skill dominated. Now, cumulative probability of live birth with age. And like we said, that the number of oocytes that you would need post-warming, and presuming most cases you have 90% survival, would increase. So if the age, the cumulative probability of live birth comes when you have about nearly more than 15, as the age increases, you will need more than 15 oocytes. So that's a large number that one will need to cryopreserve to get a live birth, because there are various factors. Now, average age at which women come for oocyte cryopreservation used to be around 38. The current data talks of a little lower. But still, if the age is higher, the take-home baby rates are going to be lower. And that needs to be counseled to the patients. And mind you, the patients have, there is what is called as the listening bias or perception bias. Patients will listen to what they want to. So if you tell them the probability is so much, they may want to listen to the higher probability, and they will think that they would be one of those. So you say a 40% pregnancy rate or a 60% failure rate. Same information, but it has different understanding. And therefore, it is very important that even if you spend a couple of extra counseling sessions, that they are very clear of what they are getting into. Now, what are should we encourage it? Yes, gender equality in employment, well, a lot of productive benefits, which were considered as discrimination against women because they needed time off for their pregnancies. And, if we could cryopreserve, we can bank oocytes, we don't need donors. All those are pros. But we should be very careful that we don't bring false hopes, because the terminology is such that they feel, and many women, and it's not that the clinics are not giving them the right information. They're not perceiving what has been told. And success rate is lower over 38. So maybe if they need to come, and I think the trend is changing now, more younger women are coming in. So that's an advantage. Again, there are organizations which are enticing women, and there was a big UN cry when Facebook and said that, we pay for you to cryopreserve the oocytes. We don't know about the fertility potential of these eggs, the implantation potential, and never forget the age-related complications. Today, systemic disorders, whether it's diabetes or hypertension, are coming at a much younger age than earlier, and then a pregnancy with that. So everything needs to be counseled and informed, and maybe give the individual time before they take this crucial decision. So there was a very different kind of study where the amount of information was conveyed to the couples and on the website, and they graded it on the scale of 2 to 11. So, and they found that most of the websites gave information average score is 3.4. So they did not communicate a lot of information, a lot of possibilities of issues that can happen post-warming or during pregnancy. Again, that means it's more to do with communication rather than the technicalities of the oocytes. And finally, as I said, it's no longer an experimental procedure. It is a procedure which most ART clinics do for their patients. But what the key factor here is the embryologist. And as you can see, it's a presentation by Peter Nagy, and you see the ongoing uh, pregnancy rate per embryo transfer, and it's highly variable with the embryologist that's doing the work. So you have this embryologist BF who has done about 18 cases in that particular month. Ongoing pregnancy rate is 22%. And you have some embryologists who have done possibly not a very different number of cases, but 60% pregnancy rates. So even if you look at somebody who has done 20, 20, 22, 42%. So realize that there's a big variation in the pregnancy rate depending on the embryologist who is doing the vitrification and the warming. And that is the key factor, because apart from the other, which is the problem of the gynecologist to maintain the pregnancy in the older age women, but this is something where the embryologist is the clue. So yes, the oocytes have quite a unique journey, a phase of quiescence, a phase of activity, again a phase of quiescence, phase of activity. And when we try to imitate all this in vitro, we need to take a lot of care to try to see we can mimic it and overcome the hurdles that come in. I realize I've shot by about 10-15 minutes, so I'm okay for any questions.
Thank you so much,
Or
ma'am. The
anything that you
idea of the masterclass is not to interpret, and it's a masterclass indeed. Thank you so much. In the meantime, when Sindhu is going to project the next set of questions, I would request Dr. Sasikala Natarajamani to, share some concluding remarks and thoughts, and then we can take the Q&A. Dr. Sasikala, madam. Okay, Sindhu,
Yeah,
madam is here. Yes,
Yeah.
yes, you are audible. Yes, yes.
Thank you, Dr. Vasundara and Dr. Rajvi. That was an excellent presentation. You really carried us through the oocyte journey. Only thing is, I have a couple of questions. Maybe if you can elaborate on that. Before that, I'm very happy that you touched upon some important points like do not inject M1 and do not inject more sperms into the oocyte, because nowadays I see a common practice among young embryologists is that they take about more than 10. I've seen in places, some places, more than 10 sperms in a ICSI needle, and then keep injecting the oocytes within few seconds. And then on top of it, no FUD check. So I think you've hit on the right point. And also about oocyte freezing, that skills are very important. About the question I was saying, what is your opinion about any other non-invasive method to assess oocytes other than morphology?
Ma'am, you're on mute, ma'am.
As of now, I don't see anything, which is there, which we can use it. There were times where people studied the follicular fluids. In fact, I myself did a lot of studies on individual follicular fluids. And what was very fascinating at that time, because we collected fluids from individual follicles, and you saw the composition was different in the same patient. And there was a good correlation with their fertilizing ability and embryonic development. Means the environment did reflect. So it clearly showed us that the cohort of follicles is not identical. But now those kind of studies are impossible, or even using them as means to assess. So as of now, I think the field is developing more on the basis of optics. And there's so much happening in the field of optics, and maybe in the future, if we can have more visualizations beyond what we see now for assessing maturity of
Some
the
studies
oocyte.
with IGF-1 and IGF-1 binding protein, zinc levels are all there. But as you said, to measure the individual follicles will be a challenge. And then you have to culture them individually. And of course, from the COC also they've done. The apoptosis and expression of genes like gremlin and Prangstin, I think. So those are there. But So yes, thank you.
Application is going to be a little difficult, but it will help us in better understanding what is happening.
But since it's non-invasive, maybe at least experimentally we can try.
Yes,
so
of
that
course.
we go nearer the truth.
So
than
that's the
blindly
reason
doing
I put the study about granulation, because are very interesting. It is possible to do it in your one's routine setup and
Correct.
really see if there is something happening there. Because why do some oocytes fertilize and some do not in the same patient?
Correct.
And there has to be something to do with the oocyte also. And I strongly believe, because I've spent nearly 5-6 years of my life looking at follicular fluids and granulosa cells and the embryonic development. So I strongly believe that it is going to be different. To expect all follicles to be similar. And it's quite interesting. Or why is it different? Because they're exposed to the same
Mm.
circulatory hormone levels. So there is something intrinsic. And if that is the case,
But
we
the
need to
milieu of each
identify.
follicle is different, right?
Yes, very different.
Thank you,
Thank you,
Doctor.
ma'am.
That
Sindhu, if
was
you can
wonderful.
share the answers, poll answers, if then we can give Rajvi ma'am 1 minute break before we, get some
Yeah.
questions which is there in the chat box. So sorry, ma'am, we are talking for 1.5 hours and I'm
No,
not
it's
able to
fine.
virtually give you a drink to soothe your throat.
No, it's fine.
Ma'am, can we just give
Sindhu,
one
you can
more
take a
minute
break.
for the poll to end, because it's 4 minutes. We'll just give it one more minute.
Sure,
So
definitely.
meanwhile, maybe we can just answer one question. So,
Your
Indumati,
poll is not visible there, Sindhu. Can you just...
ma'am, please check if it's minimized. Almost 70% have participated.
Okay.
Okay, so one question. Thank you for the excellent session, ma'am. First, pickup majority of oocytes are GB. What changes to be done for the next pickup?
I would first look at the timing of from the time of the trigger. That's the first thing one has to check, and the quality of the trigger. Because when there was a time when people talked of empty follicle syndrome, and it was considered something very special, they went and even identified it had happened in a class of Ashkenazi Jews. They are having this empty follicle. And in a large number of cases, it was found when they did a simple pregnancy test with the follicular fluid that there was no HCG. So either it was not given, or it was diluted, or the quality is compromised. Then I would look at the drugs. But first, I would look at the timing, then would be the drugs.
Okay. Thank you, ma'am. Okay, I'll just end the poll now and then we'll take the further questions.
Dr. Sasikala, if you have any other views, please. You have also a lot of experience.
No, I agree with you. I think there's nothing as empty follicle syndrome as far as I've seen.
Yeah.
In the last 30 years, I've not seen even one.
Exactly.
Even the suction machine can fail. People
Yes.
don't realize if the pressure is not enough and you don't aspirate
Yes.
well, you don't get oocytes. So,
Yes.
and one thing I would like to add is the type of stimulation.
Big thing.
If you get all GVs, probably you have to look into the stimulation also.
It's the stimulation protocol and the timing, both very crucial.
And even the type of gonadotropins.
Yes, the quality of the drugs.
And if we have ticked all the boxes that both of you have said, then maybe we can think about immature oocyte syndrome, ma'am, which is very, very rare. So
sometimes we have had patients with polymorphisms, despite we have had lot of working on the stimulations, the other factors, and then finally there are scenarios where the patient lands up with only M1s. We have worked on polymorphisms. We don't know whether it's anti-ovarian antibodies. We don't have answers. We have very few patients, and we're not able to answer anything other than donor oocytes for these patients. It's very, very minimal, and I don't think we should take this as a take-home point. I think first we have to look into all the basic aspects before even we conclude into all these advanced things.
Do you incubate them and allow them to grow for some more time, all the M1s?
Absolutely, yes.
So I find most of the times they do.
Yes.
They do.
M1s do.
Yes, ma'am. But even sometimes even after 24 hours, they don't. And for one particular patient, the second retrieval also, they had all M1s and it was M1RS.
And despite
we read about it actually.
Dual trigger, in the second cycle, we have used double trigger, all kind of things have worked. And finally, and then one more, self-assessment was the patient had another cycle in elsewhere, one more center in the similar scenario. So I think overall that could be a very rare scenario as a patient factor. But in terms of more of GVs and immatures, we have to look into protocols and a lot of other things.
Also, the good way would be whether you're seeing it in one isolated patient, then it will be patient factor.
Absolutely.
The card is the quality of drug or timing or the protocol.
Ma'am, we have few questions here. One is the regarding artificial oocyte activation. Was there any report on the effect of AOA after IVF insemination with a cumulus removal after a couple of hours post insemination?
I don't recollect, and I wouldn't see why one would do that because you'll have so much of cumulus cells, and then you're going in for artificial oocyte activation. So I guess it needs to be done post denudation.
Even I don't recollect any paper.
Yeah. Because one would not attempt it, because you're talking of a spike within 10-15 seconds. So if we are going to have the cumulus, we will not get what we are looking for.
Yeah.
Ma'am, we were talking, it's a good insight you gave us on that dispersed granulation. So you have any, data that is going to tell about the ploidy status of the oocyte? If it is a dispersed granulation there, could it be that even though it's excellent graded embryo?
Status, but it would be interesting because granular, there were some few studies which look at granularity and who were trying to do a PGTA or PGD as it was, PGS as it was called then, and found some kind of a correlation. That those kind which were granular. Now, there was no definition of granularity there. But so it would be interesting, especially if anybody has a time lapse and you are doing that. So you have better visualization and PGTA data. So if there is if people have kept
difference between ploidy status in the fine, the dispersed one which you are talking.
There is no paper as such, but it would be very interesting because we are talking of lot of this in advanced maternal age. We are talking of aneuploidies in advanced maternal age, and if you can have this, if so, one needs to start looking, and if you have a lot of pictures and you have your PGTA data, it would be very interesting to see if there is something coming out there.
Ma'am, all of us want good quality oocytes, ma'am. Is there anything, literature is quite sparse. We all use antioxidants, other medications, but in certain individuals, we predict probably endometriosis, PCOS, advanced maternal age, we know. But in some conditions, where, can we do anything to improve the oocyte quality other than this? Anything that you would want to tell us?
It's very difficult, like you said, right in the thing, how do you predict the quality? Because there may be so many other factors. I mean, PCOS and endometriosis are classical, but even systemic illnesses, chronic consumption of various drugs. I'm not even talking drug medication, because there's so many factors which affect the sperm. Whole lot of drugs. Would they or not have an effect on the oocyte? Most likely, yes. So you have maybe a couple of pages of listed drugs which affects spermatogenesis and various aspects. So at least something would be there. So there's very limited literature available on that. And that is again obvious because we don't have such easy access to sites or as one would with sperms. But then the phenomena is same in a way, the process of cell division. So could be.
Okay.
When we
Shall we go to the poll results now?
Ma'am, you were talking about incubation of oocytes before IVF and ICSI, which is very important to have a mature oocyte. When we look at oocyte vitrification cycle, what is the incubation period before we vitrify it? Do we do it immediately, or what is the difference?
So that's what we said. Keep it around 38 hours. Because we also need to, you want to do 38, max 39 hours because you want to warm and do your ICSI before 41. So that's where it's a tight balance. But the other part is that, here you are looking at, we are presuming they're apparently healthy women. So we are hoping it's one cohort, all at the same level. Like there are many studies which show that, when stimulation is done and you have one cohort and after a few days, there's another crop of follicles that start growing, the outcomes are not good. But then they also have, they are infertile. So they have other factors, maybe silent, and we are presuming these people don't have it. So, maybe it's one single cohort and we can manage with 38 hours.
Okay, ma'am. Shall we see the poll results now?
Yes, please.
So the sperm oocyte activating factor is phospholipase C zeta. Majority have answered it correctly. And which of the following characteristics of oocyte morphology is associated with better IVF outcomes? So definitely a round, evenly sized oocyte with clear cytoplasm and no visible inclusions.
And AOA stands for artificial oocyte activation. And what is the primary cause of poor oocyte quality in women over 40? So most of them is correct, but the most accurate answer is increased incidence of genetic abnormalities, mainly meiotic errors, which happen in advanced maternal age. And oocyte cryopreservation is for, this was a very basic question, but this is for everyone to understand that it can be used for all patients, like for delaying motherhood, husband unable to produce sample on the day of OPU, and patients undergoing chemotherapy, and not just for patients with cancer. And this could probably be the future also, with a lot of patients coming in for voluntary social egg freezing. So just for everyone to be aware. Need to stop sharing.
Thank you. Rajvi ma'am, last two questions and we close the session, because there are too many questions, and I don't think, oocyte is one thing that, people have so many questions, and all of us, should read about it now. Just that you've taught us so much, I think we should go back and revise. What are the effects of high cryoprotectant concentration on oocytes, and how can we assess oocyte normality after warming?
As of now, again, we are just looking at morphology and its ability to develop. I think all these protocols have been highly worked on by the cryobiologists, and there is not much of a report of toxicity. But again, the exposure time is very minimal, especially when you come to the high concentration in the vitrification medium. So as of now, there is no data which shows toxicity of the concentration of cryoprotectants used. So, but in anything in the field of reproductive biology, you can never say it's perfect unless you are going to have that, the baby is born and they reproduce. So it's always but the risk doesn't seem to be so high. And that's what a very interesting discussion that we had with Dr. Jurgen, who has been doing this ultra rapid vitrification. And, they're not seeing any problems when they're doing an immediate warming. And they're even talking about directly going to buffers, which is still something which is far away. We talked about removing all the cryoprotectant and diluting, going through the 6-7 rounds of washing. But yes, that sounds too drastic as of now. Only time will tell. But overall, there's not much of fear of the concentrations because they've all been standardized, tested. So I think we can be comfortable with that.
Last question is there any lab factors that can compromise on oocyte competence and further development? What are the lab factors that can, overexposure, whatever? I mean, like,
it's timing, handling, the changes in osmolarity, the changes in pH, the changes in temperature. It's all the lab, and the presence of the quality of lab. So the VOCs, particulate that could be present. So that could affect oocyte competence. So, it is at a very active stage. This oocyte, which has been dormant, is so active when we are getting it, and then immediately post-fertilization. So we need to give it the best environment, not a compromised environment. And I think the temperature, etc., is fairly well maintained. But when it comes to pH, it is crucial because most embryologists believe that, we have an osmolarity. If we have an oil layer, we are safe. But remember that when we are putting it into a CO2 incubator, if the CO2, the triple gas, the gases are going to get into the culture medium, there is also going to be a change the other side. So it's not that the pH is not going to change. Otherwise, if it's going to be constant, why are we putting it in a gas incubator? So there is a two-way process. So even if the pH changes, it takes much longer because of the oil for it to come back. So we need to, and osmolarity changes also occur. Oil down, it doesn't disappear. So I think these factors should be taken into consideration while handling. The simplest reasons why it happens is one can, while preparing the droplets itself, one may not see, we think that there's no oocyte in there. So I need not be so worried. But osmolarity, pH changes have occurred. pH will rectify, but not the osmolarity. So I think that's where the human factor comes in, where we can compromise a fairly decent oocyte. Or a compromised oocyte. Good oocytes would survive despite us, but the not so good ones would be in trouble.
Thank you so much for those wonderful take-home points and insights, ma'am. Thank you, Dr. Sasikala, madam, for chairing this session. And I really can't thank you enough, ma'am. I really humbly thank you for this masterclass acceptance and doing a wonderful justice. Most of us who are experienced or who just beginning to learn have benefited from this session, I'm sure, because many of us, though experienced, we don't really open the book and start reading from basics. We are all busy practitioners doing day-to-day work in a mundane fashion, in a routine way. So I really thank you from the bottom of our heart. Sindhu, thank you so much for coordinating the entire event. Thank you all the delegates who have taken your precious time, 7:30 through to 9 o'clock, full packed session. Thank you so much.
Thank you. Thank you,
Thank you,
Dr.
ma'am.
Rajvi.
Thank you, Rajvi ma'am.
Thank
Thank you,
you.
Sasikala ma'am.
Bye-bye. Bye-bye. Good night.